We can get started. So we're going to continue with applications for CT, cardiac CT, and um, essentially, most of the rest of the world other than the United States is moving towards cardiac CT because it's a cost efficient way to do cardiac diagnosis. One of the knocks against it is obviously its sensitivity to motion. And so if we look at this movie of a set of, say, 10 images taken over the course of the heart cycle, uh, we essentially make a movie every 100 milliseconds. And that movie comprises usually about around that time point. Usually it's going to require, 150 milliseconds of data. And so you every 100 milliseconds, you click along and you look to either side of it and say, okay, I'll take 150 milliseconds of my most recent data around this point, and I'll make a picture there. Because the gantry, recall, is just spinning around and around, and so you do continuous gantry spins and just make images, at some time interval. You can see this coronary artery here. This is the right coronary artery. Let me get it to this time point where I have a nice coherent picture because the heart over that 150 milliseconds that we're taking those projections around this time point, it doesn't move as much, right? And so you have a sort of a static uh, portion there. And that is usually, so that is end systole right there. And then boom, the heart comes back. So let's start at the beginning. I'll start over here. We move, the heart is contracting, and so the coronary artery is actually moving down towards the apex. And then as it gets to its most sort of apical location, the heart has ejected as much blood as it can. It's at end systole, and it holds that position for about 50 to 100 milliseconds, something like that. And so you can get a lot of data where the heart is essentially not moving at that time. And then the heart moves back as it fills up, and we get that vessel disappears because it's essentially moved to different locations over the course of the 150 milliseconds. Now you can go back to that data and change the sinograms by stretching or contracting them in time, depending on the motion of the point. So if you know the motion of the point, you know how the sinogram is going to be distorted, and you can apply the opposite of that effect to undistort it. And you can do that locally for, say, a coronary artery. And so here we'll find a situation where this coronary artery is sweeping through a number of positions. We use that information. Uh, this the we essentially look at this one or some other information to determine what that motion is, make a guess, put that into the correction, and this is the image that comes out. And you can just iterate that. You get better and better pictures, and therefore you get better and better motion estimates as each one of these iterations occur. So we can then get a motion corrected picture of the heart. And for people who have fast heart rates and they don't have a very long duration in which their heart is static, it's important to do that motion correction. Even if we look at this patient, we see the non-motion corrected image at this point is pretty darn good. We could use that diagnostically, but some patients never achieve that. You just don't get any time frame in which you have the really clear picture. Practically speaking, the nowadays, the many of the radiologists who read these scans ask for us to reconstruct motion corrected images at many time frames across the heart cycle so that they are darn sure that they're not going to have a CT exam in which they've wasted the patient's time in going and getting the exam because we have too much motion artifact. They always make sure that there's a clear picture by doing the motion correction and also reconstructing at different times across the heart cycle. Um, Another thing we can do with CT, and we'll take a look at a few examples of this, is perfusion. So we inject a contrast agent, and you can see that the left ventricle is bright because the blood is absorbing a lot of photons. This contrast agent has been injected. And instead of just looking at the coronary arteries themselves and evaluating whether or not they're narrowed down that would cause some kind of flow deficit, you can image the myocardium over time, and then this is over heartbeats, to determine whether or not the contrast is actually getting into the muscle. And so here's an EKG of a patient, and we'll say we'll take an image every second heartbeat. Oh, here, we'll skip a beat, take another image here, skip a beat, take another image here. And and then at a later time when things aren't happening as quickly, we can take images every third heartbeat. And we'll these little white dots here are the position and time of those images. And you can see here we have 0, 20, 40 seconds. So this is a fairly extended time that this acquisition occurs. And inside the left ventricle, if we plotted the Hounsfield units, we would see something like this. It would start around 100. It would go up to anywhere around 600 to 800 as it gets bright, and then it washes out of the left ventricle. So this is our input function of the contrast agent. That contrast agent goes into the aorta and then comes down the coronaries. We get very bright coronaries around here and make the images that are used to diagnose the coronary morphology. But then we can look at the myocardium after this occurs and see it enhance. Here's an example of contrast running into the different chambers of the heart at different times. You can see the first thing that happens is that the contrast comes from the decubital vein, which is in the arm. It's injected here and it goes into the superior vena cava, and that's this vessel going towards the heart. It goes into the right atrium and the right ventricle, not shown on this picture. But once it goes in there, it comes back out the right pulmonary artery that goes to the lungs, right? And then from the lungs, it comes back into the left atrium. We're looking at it at a position of the heart that's sort of on the top of the heart so that we can see all these chambers. And then there's this side pocket off of the left atrium called the left atrial appendage, which is the source of most of the strokes in people that have atrial fibrillation. And so we'll take a look later at an application looking at flow in the left atrial appendage. But it goes in the left atrium and then it comes out the aorta. This is the ascending aorta, descending aorta. And so the timing of all these events can be measured. This movie that we're seeing here is occurring over about 25 heartbeats, something like that, maybe even 40 heartbeats because we're skipping some. And we can see the contrast dynamics in different chambers. So ideally, we would be able to look at contrast dynamics in the myocardium. If we look in 3D at what this looks like, this is the blood coming into the SVC. So that bright strip down there is the superior vena cava coming down into the right heart. This is the right heart here. It goes out to the lungs, out there, it goes out to the lungs, and then it comes back into the left atrium. Let's pause this. We can do it frame by frame. If we go across, you can see superior vena cava, all of this contrast is in the right heart, mixes in there, goes out the pulmonary artery towards the lungs. Nothing else is lit up in the heart because it hasn't come back from the lungs yet. And so there's the vessels going towards the lungs. As we go on in time, we see that some of the blood has now come back into the left atrium, into the left ventricle, but those will enhance over time. So here they've reached their maximum. Here's the left atrium, left ventricle. This is the left atrial appendage, and some of that blood has come out the ascending aorta and the descending aorta. And so that's the whole 3D picture of that injection. And it's pretty cool. You can pick your heartbeat, if you will, and get the maximum contrast you need to, say, measure the left atrial appendage or the left ventricle. So the idea is we have, this isn't a movie, so I can pop this open here. We have an input function, which is the blood going into the left ventricle or the left ventricular blood pool. And so that reaches a very high Hounsfield unit at its peak. And this input function is smoothed by the fact that this blood has already taken a trip to the lungs and has come back to the heart, right? So as it goes into the lungs, it will get mixed and the bolus of contrast broadens. And so we get this nice smooth function that shows the amplitude of the signal in the left ventricular chamber. If we focus our attention on this signal, which is the muscle, it'll look something like this. At those same time points, it does increase, but it increases at a much slower rate. And well, like correction, it increases to a much smaller maximum amplitude. Okay. The rate at which it's coming up, if you normalize it to the amplitude itself, can be, pretty well similar to this. It's being driven by that injection. However, if we have a section of the myocardium, say this part here, that's this dark color, that curve would not look like this. It wouldn't come up, it would just be flat, right? It just wouldn't take it up, and then that's a flow deficit, right? So we have a few things we have to get over technically in terms of trying to measure something that's moving in a patient that's breathing in something that has dynamic contrast because we're injecting contrast, right? And so we have a few sources of image artifacts that as engineers, we got to try and get rid of them. So uh, basically, we do get intraview motion. That means what I mean by intraview is if we're taking a set of projections across the heart, we need to do 180 degrees plus a little bit. And then during those 180 degrees, all those projections, the intraview motion is how much the heart has moved during that whole sweep of angles. If you have uh, essentially a heart rate change over the course of your acquisition, and you need to acquire data over the course of multiple beats, which is the case for a scanner that's doing a helical acquisition across the heart, then you'll get big old step artifacts. When we're looking at trying to measure the actual Hounsfield unit signal strength in the myocardium in order to measure the perfusion, we're susceptible to essentially variations in the background signal due to streaking from different things like the spine, the blood pool itself, because it's become very bright with the contrast agent. And also the energy of the beam as it crosses through the blood in the left ventricular chamber, the energy of the beam when it goes in one side of the heart, it has a certain set of energies in terms of the collection of photons that go in. And then as it goes through the ventricular chamber, a lot of the lower energy photons get absorbed, and the photons that are getting through to the next side of the left ventricle, to the opposite side, they'll have basically a higher average energy. And so you get inconsistency there in how much gets absorbed. And that's called beam hardening. So here is a set of images. This, actually, those of you who are astute will see this and say, that heart's quite big for a human. This is not a human heart, I don't think. I think this was porcine. And so, but this is you can see very good delineation of the myocardial borders, great delineation of the blood pool, etc. Right? Now, at this window and leveling, so because we have very bright signal, number one, this heart, look at the brightness that we see in the basically the superior vena cava shows that a lot of contrast was injected into this heart. And so this is probably a higher contrast dose than you would do in a human. This was being done to try and image perfusion, is my guess, in an animal model. And so we have this really bright contrast here. Um, and then as we look down at the signal in the myocardium, okay, so let's focus on the myocardial signal. We've centered and windowed so that the mean value of our displayed image is whatever the mean is of this myocardium. And then we open up the window to see details about the variability and brightness of this myocardium. We've lost any detail up here. It's all saturated now. If we go back, you can see this is where we have detail in the blood pool, and but what we want to do is ask the question, well, how essentially consistent is the signal in the myocardium? If we're going to measure Hounsfield unit value, associate that with perfusion, what is the consistency of that signal? When you look at the background here of myocardium versus the blood pool, you can see that the signal is not very uniform in this case, right? And so if we're trying to measure that signal level and the change in that signal level over time to measure blood pool flow, we might be susceptible to artifacts given the high variation there. And if we look at a movie that's taken, and so now remember, each frame of this movie is usually just over 180 degrees of um, essentially projection angles so that we can make individual pictures, right? And we can see that the signal to noise of this data is quite high. We have beautiful delineation of the myocardial boundaries and the LV function. So, but when we go and look at what is the consistency of the signal in this myocardium by doing that same trick and focusing in our brightness on the myocardium, you can see there is a very systematic distortion of the signal in the myocardium, right? And that systematic distortion seems to be rotating around the heart, right? And that is because the distortion signal depends on the angle at which the gantry is imaging. Okay, so essentially the amount of uh, sort of high absorption of photons as they're crossing the ventricle changes as the position of our source and our detector change. So this, when you look at this, you say, well, I'm not really sure we have a really good shot at measuring perfusion in this myocardial signal when the myocardial signal itself is varying so much from just image artifact, right? Again, that image artifact, when you go back and look at it in sort of a normal window and level situation, the image artifact doesn't look so bad, right? And we can use this image for many things, but using it for measuring myocardial signal might not be recommended here. So this can happen in human data. This is a still frame of the signal to noise that you get in a human heart uh, during an injection. And you can see that in this heart also there is a considerable amount of variability in the signal in the myocardium. It's quite noisy, right? And so measuring perfusion there might be a little tricky. Let me see if I can, there we go. So again, the picture of the wall is fine, but we're getting a lot of variability in brightness here, a lot of variability in brightness here. And this only thing's happening here is the heart is moving, but also remember the detector's rotating, and so that's causing these changes in signal level. And when we ask the question, what is the time at which the signal reaches its maximum value? And so these colors are times, okay? So in the right ventricle, the time at which it reaches its maximum is probably between, say, 24 seconds and 28 seconds, something like that. This, I just know this from this data set. And it's later in the left ventricle, say it's about 32 seconds in the left ventricle, and then we look out in the myocardium, you can see there's a highly variable temporal point at which that signal for that voxel reaches its maximum. So again, we're at the edges, the borders of essentially signal to noise and reduction in artifact in order to get really good perfusion estimates with CT. That's why I think CT for perfusion, probably not your best choice, probably better to do MR. MR, you can get really, really spectacular data. Um, so the other thing that's been shown recently as some of the complaints about CT obviously are that you have to use ionizing radiation. And what's the optimal amount of ionizing radiation to deliver to somebody? Probably the optimal amount is zero. You don't want to give them additional ionizing radiation than the 3 millisieverts they get it just walking around. So there has been a real solid push to try and drop these doses down to a small fraction, like a third of what just the baseline dose is for staying alive. And so you can see some of these images, and the reason this image looks so spectacular is more than likely this person is very skinny. It doesn't give their, yeah, it doesn't show their mass. But you can see very nice details in these corneas with a really low dose scan. Um, Also, we can, if we want low dose and cardiac function, we can take an image only here when the heart is maximally contracted, and then take a second image here when the heart has again filled with blood. And so we have essentially a two-frame movie, but they are two very important frames, right? One of those frames, the heart is full, the other it's maximally contracted. And so here you can measure things like ejection fraction. What percentage of the blood is ejected from the left ventricle? That has traditionally been a marker for uh, essentially therapeutic decisions. It's like, is this person in heart failure? Where if their ejection fraction is less than 35%, you could say, yes, they're in heart failure. They need to go on this drug regimen. Has this person improved since their treatment? You look at the ejection fraction. If it's gone from 36% up to 45%, that's a really important improvement. So you can measure that number quite easily with just two scans. And here the whole thing is done at 1.8 millisieverts, right? Whereas doing perfusion, if we go back and ask, well, how much radiation do you need to do perfusion? If we go back to this acquisition here, right? That's over 40 seconds and it has 27 images, right? Each one of the images has very low radiation dose. And that's why the images look so grainy because we're not using many photons. But we have to get time points in order to see these curves, right? So it's hard to really drop the dose a lot when you're doing perfusion. If we're doing simpler function like ejection fraction here with 2 points, or we just take one whole heartbeat, then it's a reduction. So if we look at displaying the function as you would look at an echo with CT, you get images that look like this. Okay, so in this, there's something slightly out of whack here in that the injection for this patient was long enough such that there still is contrast in their right ventricle when there is also contrast in their left ventricle. So you can see a fantastic view of the septum of the heart and the septum here. You get an amazing view of right ventricular function, which is hard to get with echo. Uh, and this is in the classic views, right? I have short axis slices, those donut views. I can measure radial thickening. So what's the percentage increase in the wall in this direction? I can measure circumferential shortening. What's the change in the circumferential distance around the heart as it goes down? That's a strain, right? A myocardial strain. Uh, I can measure precisely longitudinal shortening. So how does the heart contract in this direction? So all of that stuff is available to us just by looking at it. We just watch the movie, right? And within, you know, 5 seconds of watching that movie, a very experienced cardiologist would tell you, this patient's normal or not. And so those are the six basic views that we've looked at, and you can get those in a single heartbeat, right? So not too much dose. Here's uh, someone who obviously has abnormal function, and I'll just let it run for a second, and you can look at it and see if you can tell where the abnormality is in this heart. Okay, it's it's not 100%. It's pretty obvious actually. So if you just look at each one, so here we look at the whole circle, and you see that it seems like the myocardium is contracting on the whole circle. Seems like it's contracting on the whole circle here. I go around here and say, well, wait a minute, what's going on here? This is actually getting thinner, going backwards at this point. This is a bit of a sensitive area because we're getting close to the valve plane. But then when we look at the long axis view and we see that our septum really shrinks down and becomes quite narrow here, well, that's an indication that this part of this person's heart, this wall right here, has undergone some kind of malady, right? It's probably an infarct right there. And this infarct was missed on echo because it's quite deep, it's pretty subtle, right? But on CT, it's pretty darn clear that you can see that this person has had a previous infarct. That was unknown when this person came into the uh, scan. We found this by surprise, actually. It was a surprise to the person. And that's just using these. We haven't done any kind of analysis or anything, just using those views. Here's a very obvious infarct in that the basal short axis looks like this, mid and apical. And so when you look at it, there's a few things going on very quickly. You're just like, well, this looks totally asymmetric in terms of how it's contracting. Only this side of the heart is contracting. It looks like the apical part, something bounces down into the apical direction, right? And and so it's sort of pushing the wall back, it seems this way. And that when we look in the long axis and try and find it, we see that there's this sort of strangely shaped thing going on here. Um, so this is an obvious infarct in this patient. It becomes instantaneously obvious. The 3D view is excellent for looking at cardiac function. We have filled the heart with contrast for this beat. This is probably at the peak of that contrast, and so we get essentially a cast of the left ventricle and the left atrium, the aorta, and where that contrast exists inside there, we basically don't see through it. This analysis for 3D, when you're looking at this movie, is done in a trivial way. All you do is cut away stuff that's like around the heart. So you just quickly cut away the stuff outside it, and then you threshold the pixels so that only those pixels above a certain amplitude will show you any kind of signal, and then you render that. And so all of the interfering signal that is below the value of the contrast agent goes away. It becomes transparent. and we can see the heart. And so you get a gorgeous view of the function of the left atrium here. You get a view of the coronaries and the ascending aorta. This is the left ventricle contracting nicely. You can see the mitral valve plane and how it's moving. And interestingly, we can also see the left atrial appendage here undergoing a fairly considerable ejection fraction there. Probably at least 50% of the blood is getting squirted out of the left atrial appendage. That's good news for this person. You don't want blood sitting in there for a long time. Okay. So in terms of how do we quantify those things? Well, we just discussed that. I'm going to put this up here. Um, this is I'm sorry, my mouse is not playing. There we go. So we did this on a problem set. So here's our CT at end diastole, one time frame at end systole when this volume is the smallest. We just look at those two volumes and use this ratio as you did. I think you did that on a problem set. And normally you eject at least 50% of the blood in your ventricle, your left ventricle. It can go much higher even when you're under stress or dobutamine or adrenaline or something like that. It can get up to 80%. Longitudinal shortening is a strain in which we look at the position of the valve plane here at end diastole, and then the chamber gets smaller. So we have an ejection fraction, but we also notice that the valve plane, so if this is sort of the mitral valve plane here, it moves down towards the apex. And that's called longitudinal strain or longitudinal shortening. It's been used in echo forever because with echo, you have a transducer down here and you look up towards the patient's head and you can see a long axis view in echo and measure that strain pretty well. We can measure it exceptionally well with CT. We can measure it regionally, like how is the longitudinal strain at different positions around the heart. And it's a super simple number. About 20% is around normal. And then when you plot LV function or just this is a plot of how much blood is in the left ventricle as a function of time. Here, time has been converted into a percentage of the R to R interval. So if this would be 1 second along here if the patient had a heart rate of 60 beats per minute. And when you calculate the volume inside the left ventricle, and this is trivial well, nowadays with deep learning, it's super trivial because the deep learning segments out the blood in the left ventricle, decides where the mitral valve plane is, decides where the aortic outflow tract begins, and it consistently puts those limits on the volume. And then you measure the volume inside that, and this is, what happens. This is in voxels. So we've got, basically what's that, 14 times 10 to the 5 voxels inside the left ventricle. And over time in systole, we reduce the volume. We sit there. These three positions would be great for doing that coronary artery image because the heart is essentially staying relatively still at that point, but it really pops open quickly and blood flows in once the left ventricle relaxes. And then we see this long tail where it's essentially at its end diastolic volume. But as you can see, it kind of drifts and fills very slowly. So this time is a good spot to take a coronary image because the coronary is not moving as much. So that's 75% of the patient's R to R interval is a good spot to set a priori and say, I predict we're going to get our best picture here. And you can still do motion correction to get rid of this residual stuff because that heart is still slightly moving. And if we're using a photon counting CT with voxels that are 0.2 millimeters on a side, as you can imagine, this amount of volume change is going to move those features a number of pixels, right? And so you even with this really small motion, doing motion correction is probably a good idea. Oh, the other feature that's interesting is this one, right? So this is the little turbocharger that is performed by your left atrium. So your left atrium and right atrium contract ahead of the left ventricle, and they put a little turbo pulse of blood into the left ventricle before the left ventricle contracts. So that's the atrial kick. That's called. This is what the inside of a human left ventricle looks like. These images were taken by Medtronic, and they're available. They used to be available online. This is a very old link. I don't know if it's still there. But what they did was they had a heart in which they filled it with an oxygenated, absolutely transparent fluid, and they had a scope in there. And so they measured you can watch the movies of this heart contracting. But the reason I'm showing it to you is because the surface of the left ventricle, especially on the free wall or the lateral wall, the left side, is inundated with all of these little tiny chambers and links. And this is called trabeculation. And you rarely see trabeculation on, say, echo, or certainly don't see it on nuclear medicine. Nowadays, you do see it on MR if you know uh, pay attention to try and image it. But with CT, this detail is absolutely visible. So you get all of these indentations because the voxels are small enough that you can actually render these indentations. And the cool thing about this is that this should move. Oh, here we go. Is those indentations actually move and you can track them, right? So here's the left atrial appendage up here contracting in the left atrium ahead. So it contracts first and then the left ventricle contracts next. Uh, as per usual, the movies are screwing up. Um, Let me try and escape out of here. There we go. It's good to see these. Okay. So we can see the left atrial appendage contracting here and the left atrium, and it kicks ahead of when the left ventricle contracts. Watch, the first thing that happens is it gets a little bigger. See, it goes whoop. It's like it breathes in before it squeezes out. However, in observing this in the early, this is but 15 years ago, we are looking at this going, we should use this signal on the surface of this heart to quantify how much myocardial strain is occurring here. Because if we know these things should track, it's a coherent signal that tracks down, we can track it while it's contracting. And here you can see in a heart, so here a lot of the additional tissues are in there. The right ventricle is in there. Essentially the pulmonary vein is still being lit up. But what I want to demonstrate with this, even though we're seeing all the right side of the heart here, is the left side of the heart, which is kind of tucked away back there. So this is the left ventricle. Look at this golf ball that's on the side of the surface of the left ventricle. That's the apex. There's this thing right here. It is not deforming at all, right? It is just being taken along for a ride. It's a pocket of blood in the left ventricle that is filling up a distended hole in the side of the left ventricular wall. It's not a leaking hole, it's just, a pit. And so that blood is not moving. And so you can just draw around that very precisely where that infarct is and where that function is not occurring, just by looking at the 3D movie. Hard to do on 2D because of the different angles. You certainly could see that abnormality though. So one thing we've done is we have created a system where you can look at that surface. So this is the essentially the trabecular shapes on that surface during contraction. So here we have end diastole here, the ventricle is ejecting blood here. We've color coded essentially the shape index, it's called. And so if you have uh, essentially a peak in a mountain range, we've colored that blue. And if you have a valley or a cup, we've colored that yellow and red. And so you can see how these positions on the left ventricle, based on the trabecular structure of the left ventricle, those things actually change and are trackable, right? And so you can link up points on this surface to those features and say, I want you to track with the feature as you try and track these points in time. This gives us a really clean signal for measuring local contraction, right? As you saw in the abnormalities that we looked at above, that left ventricular, abnormalities come in forms where they're very local, right? So this one was really local. It was only this little position here. The rest of the ventricle is doing fine, but right there we got a problem. Right here we have a problem. 90% of this ventricle is okay. It's just this local abnormality, right? And it looks like it's feeding in there a little bit. So what we want to do is make a map of left ventricular function that shows local abnormalities. And so here, um, get rid of that. So here we have an end diastolic view of a left ventricle. It moves towards end systole, right? That motion we're going to track with a non-rigid registration, uh, a program that actually maps this shape onto this shape, right? And there are many of these available, and they're used in computer vision a lot. So I want a chair, and I need to map this chair onto its new conformational position. And so you get a motion field of the points on this surface as they move down onto this surface. And so that motion field, you can link those up in time, and you get the whole trajectory over the uh, essentially R to R interval of one contraction. And then what we do is we look at a patch of those points and ask the question, how are those points moving with respect to each other? Are they coming together and forming a smaller patch, or are they getting pushed apart, or are they doing nothing? And then we'll color code that information. So here is so we start at end diastole, and basically we start with a uniformly orange heart, we'll say. As time goes on, we see the first thing that happens is we get these yellow points, and they're encoded yellow because the surface area increased a little bit. So it's getting inflated a little bit by that atrial kick. And then the ventricle starts to contract at different times across the R to R interval. And what we've encoded is the yellow and orange means we get stretching. And so this part of that heart is actually stretching. It's going the wrong way. And the blue is basically saying anything that's dark blue has contracted by about 30%. The length, if I put if I drew on the heart with a marker here, a one-dimensional line, at this point, that line would be 70% of its original length. It just shrinks down. So I get a functional map of left ventricular function. So it gives localized function. So I can see which areas are challenged in terms of that function. We do this for each time frame. And so here's the beginning or end diastole at time frame 0. As the ventricle contracts, we use deep learning to segment out the blood volume in the chamber. And then we get these vector fields that move this surface onto one, say at time 2, is this vector field, onto time 5, is this vector field. And so now we'll have a mapping of that, and then encode how the area how a area patch changes at a given spot, okay, at time t. So this is the area at time t of this spot divided by the area it started at time t0 at this labeled spot. Take the square root because it's the essentially nobody thinks in terms of areas, in terms of fractional change in area. That's a hard thing to think in terms of. So we take the square root and now it becomes the fractional change in a line of one dimension. Okay, and that's called the regional shortening as measured by CT. We can make those measurements at different segments of the heart. And so this map here are 16 segments of the heart. And those 16 segments, remember back to the bullseye? The bullseye had 16 segments, actually. It has essentially six segments on the outer ring, six segments on the middle ring, and then four segments on the apical part. So here's the six on the big outer ring, which is towards the base. This is the middle of the heart, six segments, and the apex. What we've done here is for, I think this is about 20 individuals, and these are patients who came in and had CT done. They were looking for coronary disease, and they didn't have coronary disease. They were normal. And so what we did was with those patients, we did the analysis of their left ventricular function, which also proved to be normal, and measured the curves at each location on their heart. And so everybody starts at time zero. This is the R to R interval. So I've got time zero and then 100% of the R to R intervals here. This is the heart contracting to end systole. So it's remarkably consistent in terms of when that happens. And then this is the heart relaxing back and then in diastasis. Okay. So you can see this is a reproducible strain pattern, and we can measure it with this kind of resolution at 16 segments around the heart. You can do it with higher resolution, actually. We can go up, my guess is about 48 independent segments. After you get past 48, things start to be correlated with their neighbors, but I would say about 48. And so you can see there is some difference actually in how quickly it contracts and then how quickly it relaxes. And so this whole thing can sort of shift back and forth a little bit in time. But for the most part, end systole is somewhere around 35% of the R to R, is what you'd say. If we average all those data together, we get this thick black curve here. And so that says, yep, I've got my, on average, at each location on the heart, we get a 35% position of the minimum volume. So I would need to measure this volume to get ejection fraction. And then I can measure this volume as my end diastolic volume. Right? The smaller or thinner black curves give one standard deviation around the mean. And so if I plot this normal curve against a patient who has heart failure with preserved ejection fraction. So their heart is contracting and essentially achieving a normal ejection fraction or close to normal ejection fraction. But when you watch, when you either look at the shape of the heart, as we looked at problem set one, it's getting to be more spherical, or you look at the timing of the contraction. When you look at the movie, it looks slightly abnormal. And so you can see region to region, this red heart here, this patient does have a different looking strain curve. There's a couple of things. One, it seems to be centered so that it's almost like a sinusoidal squeeze box type of thing that's very symmetric, around 40%. Also, the rate at which it is relaxing is remarkably different, right? So these are all relaxing much more slowly than normal relaxation. And so when you watch the movie, it has this kind of viscous feel to it. It looks like it's having trouble relaxing and opening back up and filling. And so that is, we found in doing studies with these patients, probably the soonest or the basically the predictor that predicts ahead of time the most for the onset of heart failure is this diastolic abnormality. So here's a movie of, now again, this is in a porcine heart, I believe, and so this heart rate will be quite high. This heart rate's probably about 150 or something like that. And so I'm going to jump out of, there you go. So I can play the movie and it will play well. Um, so you can see there's an interesting artifact in the motion of the wall, right? In that it looks like there's a double wall on occasion, and it's almost like it's clicking around uh, the heart. So it's click, 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 goes around, and that essentially is sensitivity to motion artifact depending on the gantry angle. Those it becomes a pretty complex problem actually when you ask, well, what is the motion artifact of a donut that is decreasing and increasing its radius while I have a CT scanner rotating at a specific rate around it? And so this motion artifact is something you really want to get rid of as well when you do cardiac function. If I want to measure when does this wall contract inward versus this wall contracting inward, I really do have to do motion correction in order to get the timing right. Otherwise, the timing is shifted one way or the other depending on the relationship between when that contraction happens and where the gantry is at the moment that you're making that image. So motion artifact is important for doing LV motion as well to, to get it correct. Okay, so the next, are there anybody have any questions or anything on that? If if you do, because I'm closing down the visuals here of who's on the call, just speak out and I'll stop and ask, get your question answered. Okay. Okay. So now what we're going to look at is uh, atrial fibrillation, which is something I think CT has a lot to offer because atria are small, essentially, and the features of the atria sometimes that are interesting are quite small, and so they're hard to image with echo or MR. Secondly, the atrial or the essentially left atrial appendage, when you're in AFib, it undergoes kind of random motions, right? So that what happens when you go in AFib is there's an electrical instability in your atria. And so they're sending off electrical signals to beat at essentially a random number generator in terms of when that occurs. It doesn't have a Gaussian probability density function, but the R to R intervals are random. And so the problem there is if you're counting on multiple heartbeats to make some high quality, high resolution pictures, which you certainly are with MR, and you certainly are with SPECT. The problem is there that you uh, the image artifact can sort of blow your signal out of the water. Um, with modern CT scanners, this is where I think the CT scanners that have the wide detector, such that you can image the entire heart in a single rotation, they have a tremendous advantage for these patients, people in AFib, because you really only need one good beat or a QRS, and you can make an image of that beat. So, uh, in looking at what we can do for patients in AFib, we can look at the tissue itself. This is mostly with MRI, if you inject a contrast agent, we'll see this called gadolinium. It will stick to places in the left atrial wall that have been infarcted, and so you can kind of get a map of how much of the left atrial wall is still alive. Um, you can image the motion and the shape of the left atrium very well with CT. And the other thing you can do with MR is when a treatment for left atrial fibrillation is that you isolate the pulmonary veins by killing tissue in a circle around each pulmonary vein. And with MR, you can actually see where you've made those burns, which is very useful for later after the procedure when they go back and if they get an MR, and it's a big deal to get an MR for this, and you can look at how the burns uh, have enclosed off the actual pulmonary vein, or if there's a gap in the burn, that's a problem. Um, and you can look at LA fiber orientation, but that's sort of second level stuff. We did some interesting papers with diffusion tensor MRI, looking at really detailed fiber maps of the atria, which has been quite helpful for model building. But I'm not sure you do that in every patient. That was a hard thing to do. But function with CT is pretty straightforward. What's done now is a thing called the Chad's VAS score. And if somebody has atrial fibrillation and or you're trying to evaluate their probability of having a thrombus or a stroke, and whether or not you should put them on an aggressive anticoagulation therapy, which sounds like, well, so if you put them on it and they don't actually need it, is that a problem? Well, in older people, if they fall, it's a big problem because then they get these big hematomas and things if they fall. Also, if they're already susceptible to a brain bleed, they can have a massive stroke, like from a brain bleed. And so you don't really want to put people on anticoagulants who don't need it. And whether or not you titrate the dose is another question. So what they do now is they look at each patient and they ask, well, how old is the patient? What's the sex of the patient? Do they have any of these things? Heart failure history, hypertension history, previous stroke, obviously that's a big one. Vascular disease history, so do you have coronary vessel disease and diabetes? Each time you have one of these positive, you click on a one on here, except for stroke, you click on a two. And if your number gets above a certain value, then you go on an anticoagulant therapy. And you know that's all well and good, but when you look at this score and you ask, is this score predictive of who's going to have a stroke down the line? It's not a good predictor. It really isn't. And it's not that surprising because other than one thing, which is have you had a stroke before, which is a big deal, everything else doesn't really look at what causes stroke, which is lack of flow of blood in the chambers, right? So if the blood is static, you're going to have a much higher probability of stroke. And there is no blood dynamics in here at all, right? These are all other uh, features. Whereas if we look at what we can do with CT, we have these gorgeous pictures of left atrial function, right? So we just have a movie here of what is going on in this person's atrium. This person obviously is not in fibrillation, right? Atrial fibrillation. You see the roof of the left atrium has a nice downward thrust at left atrial contraction. These are pulmonary veins, the four pulmonary veins coming in. This is an interesting signal, right? This is where the contrast is running out. So basically, the contrast has dropped to a point where this is just kind of blood, fresh blood, and you can actually see that flow. Nobody uses this to measure flow, but obviously you can see the flow there. But we see a couple of things. We see early atrial contraction. If you look at the mitral valve plane, it goes up and then down with ventricular contraction. So we have the potential to look at atrial function, and even better, we have the potential to look at left atrial appendage function. And so here is a left atrial appendage, this thing that looks like a little cauliflower here, and watch how it goes burp, and it just like contracts and becomes 50% of its size. So we can go to that frame and we see there's the left atrial appendage really nicely, and then bang, and it contracts right down there. So it's become very small, right, at that point. And so that patient has really good left atrial appendage function. What CT can do is make really nice renderings slash measurements of the volumetric picture of a left atrial appendage. And these vary from person to person considerably, right? One person has a completely different geometric left atrial appendage than another. And the what you can do is if the person is in profound atrial fibrillation, you can look at the geometry of that and then size that left atrial appendage to fit it for a closure device. So these are the struts of a closure device called a Watchman, and it has on top of these struts basically a fabric. And what is done is this whole thing can collapse down. Do I have a picture of a Watchman getting put in? I don't. Sorry. But this whole thing can collapse down onto essentially a catheter, and you push that unit into the left atrial appendage, and then you pop it open such that it looks like this, and it opens to fill this gap entirely, right? So these struts hit the walls along here, and then you have essentially isolated the left atrial appendage from the rest of the left side circulation. And then this is a little screw uh, receiver, and you unscrew the catheter that you brought it in on, and you pop it off, and you just leave it here. And then ideally, it just endothelializes, and you get a nice smooth surface, and you have completely isolated the blood in that left atrial appendage that was not flowing. Now, sometimes transesophageal echo will be done to try and evaluate whether or not the left atrial appendage has flow in and out of it. However, that data is pretty hard to reproduce, and so not something I would trust that much. But CT, you can see this fantastic geometrical uh, rendering of the organ. Plus, what we can do is we're going to do a contrast injection anyway, right? So while that contrast is flowing in, as we're going to make a cardiac CT image for this patient, every patient who's going to go to the cath lab to get their atrial fibrillation treated with ablation therapy, that is putting those ablation circles around the pulmonary veins, everybody who goes for that gets a cardiac CT. And that's so that they have a geometry they can map onto where they made the burns. And so when you're getting that CT, you're going to make an injection. So here's the contrast coming in the right side, coming in the left side, and then going into the left atrial appendage right here. So this is the bottom, this is the apex of the heart here. What I've done here is I've cut through this volume, the left atrial appendage volume. So the purple, which is this guy, is this cross section along here. And you can see here's the end of the left atrium. This is the left atrial appendage, and it fills up with contrast, but it doesn't fill up very uniformly in time. So here we can see at this time frame, we have a lot of contrast in the left atrium. But when we look up into the left atrial appendage all the way to the end of it, you see that contrast hasn't made it there yet. Whereas at a later time, we see the contrast has made it to the end of the left atrial appendage, up to the end. So we can get dynamics of blood transport inside the left atrial appendage, which really is not available by any other technique. This is a really cool application, I think. And so if you look look at this plot. So here, the left atrial appendage is coming up here, and we're just going to cycle back and forth in time. You can see it fill, right? It's half full, then it fills. And so now we have this estimate, and you can see it'll probably delay. It stays in there longer. Now, now we have actual information about dynamics of blood moving around in the left atrial appendage that we can make a sensible prediction as to whether or not this person has a risk of forming a clot. So these are just Hounsfield unit values obtained inside I don't know, it's probably that patient that we have on that other slide. This is time in seconds. And then this is the time at which each scan is taken. This, you can read this in the header of the DICOM file. And then these are the Hounsfield unit values in the left atrium, the proximal left atrial appendage, mid left atrial appendage, and distal. So if we go back to the picture and we set this, okay, so this is proximal, mid, and distal left atrial appendage. So we've broken it up into three locations, right? We ask, is the flow any different in those three locations? Proximal, mid, and distal. And this is proximal is orange, mid is this, and distal is this. This is time, this is Hounsfield units. So you can see there's a long delay in trying to fill the distal part of that left atrial appendage with contrast. And in the midway up, there is a delay, it's not as much. But this patient, you would say, has flow that has been compromised by their atrial fibrillation. And it's a pretty cool application. If we go back and we ask, what is the time to peak of the contrast curve as a function of position? So for every voxel in this heart or in this left atrial appendage, we're going to measure the time to peak. And so we fit this curve and ask, what's the time to peak that that voxel reaches? And you can see as we move towards the distal part of the left atrial appendage, that time to peak goes up and up and up. So finally, we're here, we're almost at 35 seconds, whereas down here in the left atrial appendage, we're filling around 20 seconds. So now you have a really detailed diagnostic map, I think, of blood transport in the left atrium or the left atrial appendage. These are time to peak estimates here in 3D. So we can see this is the left atrial appendage here, and you're seeing those time to peak estimates at every point in 3D. So we have them over the whole 3D volume. There's another, did we talk about perfusion? Yeah, I think we did. Okay. So this is time to peak again. So let's go back and just think about myocardial perfusion. This is the kind of noise you get on a myocardial perfusion estimate of that time to peak, which is too bad, right? It would be nice if it was a lot smoother. It does seem like maybe the time to peak is lower over here on average, but I'm not sure I trust it because as we saw all those artifacts before. But we've got time to peak for our left atrial appendage, which is what we're after here, right? We can measure that in a bunch of patients in their distal left atrial appendage. And we can see that a number of these patients have very long time to peak, so very delayed filling of those left atrial appendages. A bunch of them don't, right? These are all folks who have virtually 2-second delay between their proximal left atrium filling up and the distal part. So these folks, half of whom in this bundle here are in atrial fibrillation, right? Those folks in atrial fibrillation inside here probably do not need to take a blood thinning drug. right? Because the flow transport is just fine. These folks down here, I don't care what their CHADS VAS score is. I think you're going to want to put these people on an anticoagulant, right? Just based on the fact that it's so sticky and viscous in their left atrial appendage. Okay, it's 10:40. So we'll leave it there. So those are a bunch of applications for cardiac CT and a couple in great detail. Uh, and hope you enjoyed those.